Thank you very much. So we're thinking to start this easy and just maybe just tell us a little bit about his story. All the topic is about a brain tumor, and even if you have never heard about this before, this weird name, medulloblastoma, I hope at the end of this lecture you will try a little bit to understand what a medulloblastoma is, how the treatment looks like, what the outcomes are, and especially what the long-term outcome are. Because for us working in pediatrics, it's also important. We're not just looking down the road 1, 2, 3, 4, 5 years. Josh will tell you how many years he's already looking down the road, but for us really the goal is to get a healthy adult who will die at the age of like 89 with tons of grandchildren and grandchildren and had a really successful life. Josh, can you remember a little bit how this all started?
Well, it started out as me just vomiting periodically, and then my parents ended up taking me to the doctors, and they said that it was acid reflux, and so then it stopped for a bit with the medicine, and then it just started up again, and then it was almost a daily occurrence. And then one morning I vomited a second time, but that time I was holding my head screaming because it hurt so much. I was 7 years old at the time. 9. Okay. And then from there, my mom took me to the hospital, and then 2 hours later, we found out that it was a brain tumor.
Drew, how was this period for you as a parent?
It was like getting kicked in the stomach. Rena, as Josh said, my wife had taken him to the hospital, and it was a quick ultrasound, nothing in the stomach, but because he'd had the headaches, they did a CT scan, and it was quite a large tumor, so it was quite evident right away. And then I was leaving at noon, so Rena had to try and get a hold of me to tell me what was going on, so that phone call I'll never forget. And then just rushing to the hospital to get there to see what was going on and what our next steps were, and they were pretty good. We were the ones that ended up telling Josh. The doctor asked us if, do you want me to do it? And I said, no, I'll do it myself. And so we told him what was going on, and we never ever lied to him. We told him the truth about everything. Sometimes we didn't elaborate on too much, but if he asked a certain question, we answered that question. But, still trying to keep things as positive as possible. That was a big thing for us, making sure that we stayed happy. We laughed, we told jokes, we picked on each other, but there were days that were certainly not like that.
Josh, what do you remember from the first days in hospital?
From the first day in the hospital, is this before the surgery or afterward?
You can tell us about both.
Okay. From before the surgery, it was just a week and before, and then I basically had to keep an eye on all the stuff that I was eating and drinking, and then other than that, it was just preparation stuff for the surgery, and then other than that, just watching movies and seeing people. And then after the surgery, I don't remember a lot other than the fact that I was in ICU for a bit. And then after that, I was in the hospital for a month, I think.
He doesn't remember much. So, from the pre-surgery was 5 days, just to try and shrink the tumor as much as take some of the pressure off the brain, and a lot of tests, a lot of preparation for that June 25th date. And then after there's no memory, he has no memory really for 30 days. There's kind of everything shut down, and which is fine because those were not glorious days. Those were the hardest ones for sure, of the falling into posterior fossa syndrome. So his arms and legs were just all over the place constantly, and slowly lost his ability to talk, couldn't open his eyes. If you opened his eyes, they were pointing in different directions. So there's it was slowly, all that would come back. But still has issues from the ataxia that he had. Had a small stroke after the surgery as well. Not too much effects from that, but the whatever happened up in here affected he can walk not too bad, but it's a lot easier just to stay in the chair and function that way. So especially going back and forth to school.
You for sure remember the day of the disclosure when you were told what it is and how the treatment looks like.
Yeah, I mean, Rena she hears brain tumor and she's like, yep, it's cancer. For me, we got the book on brain tumors and it's like, not all of them are cancer. Great, let's go for one that's not cancer. Well, sometimes those ones are worse than the cancerous ones. So when they came out and said, Dr. Hollenberg said that it looks like it's a medulloblastoma, I can tell, you've seen lots of them, so they can tell by the look of it and the color and such. And yeah, I kind of lost it. Thinking, oh great, here we are, cancer, this is not going to be good. That means, I can't say that one word, but you know what I mean. And that was tough, very, very tough. And ICU was a horrible place. I never, ever want to go back there again. But overall, it wasn't as bad as, I mean, again, dark days, but it got better. Each day seemed to get a little bit better.
What helped you as a family to move forward and go through this intense treatment?
We always stayed positive, joked with each other, made fun of each other. We just tried to make things as normal as possible.
Rena's from an Italian background, so the Italian side of the family was very mothering, very put him in a plastic bubble, don't let anybody touch him, don't let anybody breathe on him or look at him. My side of the family is different. You know, it was the same, don't treat him any different. If he did something wrong, he got in shit for it. I was I'm the tough love and Rena's the soft love. So we balanced each other out that way. But, you know, it's as he gets older and we were getting through all of this, I wanted to make sure that if he fell down, that he got up. I didn't want somebody else to help him up. He had to learn how to fall down properly to protect himself, and then he had to learn how to get up on his own so that, you know, he could be self-sufficient, because hopefully he outlives us. So that's important. He has to learn to live for himself so that he can be independent.
Josh, how did you experience treatment? I mean, it's a long and relatively intense treatment, lots of things happening in the hospital.
Sorry, can you say that?
Just like the long period in the hospital and the really intense treatment, which was quite some side effects, I would say. I mean, you were not feeling well all the time.
Radiation and chemo.
Yeah, and radiation and the chemo, that took a big toll on me.
He doesn't remember the radiation part of it. That was...
Well, some of it, but not much.
Yeah. He had to be knocked out every morning because he moves around too much, so he has to be perfectly still for all those radiation treatments. And that was hard on us, seeing him put to sleep every morning, you know, for 6 weeks. Yeah, 31 treatments. So, and then, you know, the blood starts to become affected, and the blood transfusions, and you think, oh my God, now I've got somebody else's blood has to go into him, and then that whole anxiety of, I don't want this to happen, but it has to, because otherwise it just doesn't work. So, and then chemo started, and that was all watching these drugs go in. Okay, what are they going to do? Are they going to make him sick? Are they not? You hear all the horror stories about just losing all this weight and vomiting so much and becoming pencil thin. And it wasn't as bad as that. Out of the 4 rounds that he had, or the 4 chemos that he had in the 1 round, only the first one made him vomit 1 time, and that was it. And then he would be okay.
And right back to playing PlayStation.
Yeah, right back
Vomit.
to it. Yeah, where's my ball? Okay, now can I have something else to eat now? So he knew it was important to eat. So we tried to force as much into him as we could. He had to eat very slowly because his gag reflex is so sensitive. One little bit of food in the back of the throat, an hour's worth of struggle to get it in, gone in 30 seconds. So.
And it was hard because I didn't like the hospital food.
That hasn't changed.
But he had the Italians to cook for him.
So the supply was good.
The supply was pretty good. Yeah.
And then one day was the last day of chemo.
Yeah.
November 6th, 2004.
Was
day.
this an extremely happy day or also like a little bit of a scary day?
Yeah, that was an extremely happy day. Remembered the pharmacist at the time, he brought me my very last chemo bag and wrote a little note on it and gave it me.
It was great because everybody
Yeah.
treated him so well. He's not a complainer. He smiled all the time. Practical jokes on the nurses. They would wake me up with a syringe of water from across the room. That's what we liked. That's what made it easier for us to deal with.
But
So.
you dished it right back.
Oh,
too,
absolutely.
so-
I gave it right back to them too. Any practical joke that we could get. Josh had a little water camera, and he got a nurse. She got right in there with it, and he squirted her right in the face with it. Those are the things that you remember. And he wanted to come to the hospital. Shift change at night. I'm thinking, okay, I got to wait till after this time to go for his in-hospital chemos, and I was like, I just don't want to go. And he's like, come on, let's go. We're going to miss the nurses. I have to say goodbye to the ones that are leaving and meet the new ones. And he's the one that wanted to come here, not me. So that made it easier because it was easy for him. It was easy for us to deal with as well.
Sometimes.
Sometimes. Yeah.
Sure.
Yeah,
And that,
November 6th was a glorious day to finish. We had a big party at home.
Good.
We celebrated everything, every little milestone, even though we didn't know what was in the next week. We celebrated that day because that was a big milestone to hit.
and then Josh, like, how was it for you to go back into your previous life, which is a different normal now?
It was definitely different. Like going back to school, it was kind of easy. Like everyone welcomed me back, and it was almost like nothing happened. Like I just missed a few days of school. But like there were limitations to the things that I could do, you know? Like with my hearing and this and all those other little things. Those were different and hard to deal with, but over time they got easier, and now it's my life.
How was it true for the family to have the focus completely shifted a little bit?
Yeah, again, we tried not to focus too much here. Rena would have to talk to her parents to say, ease up a little bit. But it was harder. I mean, we have 2 other boys, one older and one younger, so we wanted to make sure that they were included in decisions. The older one, for a long time, because Josh couldn't even sit on the toilet by himself, somebody had to sit right there and hold him. So when your older brother is actually helping you to wipe, that says a lot about your family. They throwing up at the table constantly. Restaurants, gag, boom, there it goes, and everybody kind of just huddles around a little bit to try and make it so that the rest of the restaurant isn't affected by what's going on. We tried to And then we would joke, and he would laugh and spew food across the table, and you know, that's our daily life at our dinner table. So
You have to draw straws as to who sits across from him.
yeah, don't sit across from her. But it affected everybody. But our extended family really stepped up as well and helped us, just to give us some time too. You know, to just to get away for a weekend. You know, that was a big thing. Because you're around him 24/7. We slept in the same. One of us would sleep in the living room on a futon on the floor, because we were afraid he would roll out of the bed because he moved around so much, and it was just easier and without being able to talk. So if he needed something, we had to figure out what it was that he needed. So we would spot each other. One day it was in bed, one day it was on the floor with him. So, but it worked. We made it work.
So Josh, what are your plans for the future?
In September, I'll be going away to Conestoga for college for a few years, and then after that, I hope to do another cross-Canada bike ride.
Maybe you have to explain the audience why are you wearing this jacket.
Okay. So 2 years ago, me and this lovely woman, we traveled, I traveled across Canada. She traveled across most of Ontario.
Thank you.
And so there's the story again.
That's
How
right.
much money did you raise, Josh? Tell everyone how much money you raised.
I raised just over $80,000.
It's an amazing feat for somebody in a wheelchair to be able to ride on a tandem bike across Canada. There's a lot of training involved. And the training actually helped his breathing, helped to strengthen his vocal cords. You can hear he's got the shake in the voice. But prior to the training, it was very pronounced, and some people didn't even understand what some of the words he was saying. So getting into swimming and biking has been tremendous. Fun things even, you know.
And he's
Video
a very
games.
fast cyclist, let me tell you. It's hard to keep up with him.
Yeah. Video games helped as well. Hand-eye coordination. You don't want your kids playing video games, but in a situation like this, it was very beneficial. What else was he going to do? Lay there and watch TV? And his brother, he bought the PlayStation when it first came out, and his brother went outside to play, and I came in the room, and Josh is sitting there watching this frozen TV. And I said, well, what are you doing? He said, well, I'm waiting for Kyle. Well, I said, Kyle's outside playing. I said, well, here, take the controller and you do it. And he said, but I can't. I'm going to keep losing. You got somebody somewhere else to be? Take it. Keep going. So he would lose, and then he would start over, and then he would lose, and he would start over, and then it got better and better, and his eyes kind of seemed to come into focus a little bit more because he's using those muscles, and everything was in here, but it was really hard for him to get it out of his mouth. That was frustrating at the very beginning until his speech started to come back in. So he didn't talk for 6 or 8 weeks, and then it sounded like he had marbles in his mouth, and slowly that got stronger and stronger.
And it's unusual to hear your son's first words again to be mom again, mama, for the second time around.
Lots of firsts all over. Again, those were sweet milestones to hit. So,
And how many years will it be in September?
In September, it'll be 10 years.
amazing ride. Out of something so terrible, we've tried to do as much positive as we can. We're a member of a Work for a Cure committee in our own hometown. We raise money. We've raised almost $500,000 in the past 5-6 years. Josh won the Queen Elizabeth Diamond Jubilee Award this year. He rode across Canada. He was a part of the Rick Hansen adventure across Canada, the 25th anniversary. Made a difference maker. They flew us out to Vancouver to be on the show. I don't know if anybody saw it on TV, but I was there too. In the audience, but I was. So.
And he's logged 750 hours of volunteer hours as well.
Over his high
over
school.
his high school career.
We're only supposed to do 40. He did almost 800, so. Yeah. We throw him into as much as we can. Again, we laugh at everything. Our other two boys poke fun like you wouldn't believe. You want to come over for dinner and witness it? Feel free.
Just don't sit across from
No,
Rob.
don't sit across from him.
Oh no, if you draw the wrong straw, you're
Yeah.
Yeah,
you're across from
Yeah.
him. So.
it will happen.
Are there any questions from the audience? Brennan.
Josh, thanks a lot for all that. So I guess there's quite a few med students or students who want to go to med school here, and I think one of the things that I want to ask you and your parents is, what are some of the things that the doctors did that made you feel really comfortable when you were there, and what were some of the things that you wish they could have done differently, so that when we see patients in the future, we can apply those to our patients?
Well, Dr. Hollenberg, one of the very first things that he said to me was, you can call me whatever you want. It was Dr. Hollenberg, Dr. Hamburger, anything, really. And then just all of the nurses, both before and after, they would spend time with me. They would talk to me, joke with me, squirt my dad with water. They didn't make it feel like a hospital. They made it kind of almost feel like a second home to me.
One thing not to say is, are you okay? We had quite a few nurses say that, and there's 3 or 4 days of not sleeping, and then one nurse just had to say, are you okay? Is everything okay? Well, of course it's not okay, you know. We were devastated, and I snapped. And I apologized afterwards, and she understood too, but it was just, of course we're not gonna be okay. We're in there because our child has a life-threatening situation going on, so don't ever say, are you okay? Is there anything I can do for you? Would be better to say than, are you okay? I think that's the only negative thing that really bothered me anyway. I don't know about my wife.
Rena, do you have advice for the med students and the future doctors?
I mean, Dr. Hollenberg was amazing, and I remember the day of Josh's surgery, and he came in, and the first thing I asked him was if he'd had his coffee yet, because he needed to be steady. And you know, one of the last things I remember saying to him is, you know, treat Josh like you would treat one of your own children. Just remember.
That's really good advice.
And then they both started crying.
So then he gave me a hug.
Yeah.
And, you know, and I sent him off, but it was difficult. I mean, even 10 years later, it's still not easy to talk about.
Yeah. We're in your hands when we come here. I mean, there's no cancer in either one of our families, so to all of a sudden be thrown into that, you know, we don't know where to go and what to do and who to turn to and who do you trust, and you know, here's my kid. Okay, now do the best you can with this, and you know, you want the best outcome. You know, we've had some issues, and there's cataracts and hearing problems, and still an A student, which is the best part of it, still has his personality, which is the best part of it. We can deal with the rest of it. But, you know, we're in your hands, so treat us like you would treat your own kid. And that's one of the best things to say. You're going to have bad days too, but I did have a nurse say to me that she was having a bad day, and that didn't go over very well either. You know, you're having a bad day. Well, I'm having a really bad day. You get to go home and be with your healthy family, and I don't. So, you know, you got to be careful how you say things to people that aren't sleeping very well, especially in the hospital. Overall, it wasn't bad.
Thanks. Any other question? Thanks for sharing this really amazing story.
No problem. Our pleasure.
So it's a little bit hard now, I think, to move on, just like to really to feed this a little bit into with facts. You have seen this, so I think Josh is a really good example of what you can really do, even like if you have to like really struggle with certain things, but if you really want to do something, don't get discouraged, and you can really do it. And I think you met a lot of like amazing people through this journey, at least the part I was there, and I think that's really something which also makes it really amazing for me to do what I'm doing. You have all seen the objectives, and we touched already one, which is like really the patient's part. I want to touch base on now a little bit like what Josh explained as a patient, what really the clinical parts to this is, and why it's something for us so important. If you're looking at brain tumors in children, you will say, I've never heard of anyone who had this, and this is really a good thing. It's thankfully overall seen something really rare, as it is that a child has cancer. But for us as being the expert here, that's something we have to deal with it quite regularly. And medulloblastoma is one of our like really most common tumors we are seeing. And as you can see in Josh, with quite a lot of challenges in diagnosis, treatment, as well as the follow-up. So for us, it's really the most common what we're seeing malignant brain tumor, so something which is relatively aggressive, which with this, as you have seen in Josh, relatively quickly from like really symptoms that something really bad is going to happen and you are coming in. It's classically more or less a tumor we see only in children. So that's not a tumor we see in adults, only in young adults. So more or less once you are like over 25, that's not a tumor you will see in this population. And it's a tumor which starts out of the cerebellum, so like really of the low part of your brain here, and I will show you a little bit like of a picture later, which explains some of the symptoms Josh has experienced. Over the years, you're always thinking, so like at some point, someone saw this tumor first and described it as this, and this for sure was like how this whole discipline developed by a neurosurgeon. And the first treatment we could only offer was just you're going and you take it out. You had nothing else to offer, and was like this nothing else to offer, the tumor came back. Then over the years was like, do we have any other treatment modality to like really get like this for a longer time, the tumor doesn't come back. And the next thing what we had available was radiation therapy. Not in all this like really fancy way and setup and simulation and everything like we're having now, and everyone who's maybe been up at the JCC and these like all the work behind before we even getting a patient to radiation. No, it was a little bit like you had a lot of like burning everything. With this, you did not only unfortunately treat the tumor, but a lot of like the surrounding like really healthy tissue. And then a step further, someone had the crazy idea to use chemotherapy. And a lot of people were thinking, why would you use chemotherapy? Because we have something which is called the blood-brain barrier, which normally is a really good thing because it really sort of like really protect your brain from that some of the toxic substances are going there. But it's also a major challenge that something good as the chemotherapy is going there. So we don't have a lot of drugs who are really successfully crossing this, but the implementation then of the chemotherapy was the step to have finally some survivors. And then based on the survivors, and we are really good in pediatrics to really document everything and collect all of this documentation. So every single patient who was treated, we collected as much clinical data as we can have to come up with this list a little bit of factors where we could think someone is considered a so-called average risk and someone is considered a high risk, and adapt a little bit the treatment like this. Age is a really important factor. Less than 3, this tumor behaves differently, and it's maybe even biologically a different tumor, even if we have the same name. Things will make sense, clearly, if you could either take it out completely or if there is something left that will influence your treatment. This tumor can also have metastasis, so can have them spreads outside of the brain and the spine. And you would think, sure, the more tumor burden you have, the more intense you have to treat this. And then the other thing which came through as our pathologists become better and like really looking under the things under the microscope, they could distinguish different kinds of medulloblastoma. So it wasn't one disease any longer. And so we had certain subtypes who could influence this. And with this, you can see that you have to fulfill a lot of criteria to fall a little bit into the lower risk group. But that's clearly a lesson we learned, because if you have one of the high-risk feature and you don't treat this appropriately, the tumor comes back, and that's what we want clearly to avoid. Metastasis, and that always sounds like really horrible, and everything you have in mind always comes from the adult world, where you always hear metastasis that puts you in a complete different risk group, and it's completely bad. In medulloblastoma, as you can see, the number of metastases at the time of diagnosis is relatively high. If you see kids, around 30% of them already have metastasis. But we know how to react on this. So it's not automatically meaning with this we can't do anything. We know how to really adjust of our treatment. The interesting part is that most of the brain tumors stay in the brain. So blood-brain barrier working on the other side as well. There are a few cases in medulloblastoma where you also find this tumor outside of the CNS, mainly in some of the bones as well as the bone marrow. Extremely rare. It's so rare that in my personal career, which I know I have still a few years ahead of me, but I personally have only had one patient who had some disease outside of the CNS. As we're now going, how are we figuring all of this out? Clearly, in our days, the standard of imaging is MRI. So all of these patients, and especially as you may know in this province, we have only 5 centers who are treating kids with cancer, which is besides us, London, the Hospital for Sick Children, Ottawa, and Kingston. And we all have MRIs, and we are all set up to do this for the younger kids. As you know, they can't lay still for such a long time to do this with anesthesia. So an MRI of the head and the brain is really standard. And you should do this, presumably the whole spine included as well, prior to the surgery. It's just easier. After the surgery, you have to wait a little bit time because the surgeon, there are some blood products, and this can give you a little bit like a false impression if there is something or not. So we have pretty much the standard here. The kids are coming in, we have a high suspicion, and we just do the brain and spine in one session. Josh, you know it takes a long time. An MRI like this is 1.5 hours, so we have to be really careful and really see ahead if we think the child is able to do this without sedation. And if not, we get anesthesia. Because the worst thing could happen, like the kid is having a panic attack in the scanner or can't really do it, then we have not won anything, and then we lost a little bit of trust. The other thing, how you can see if there's metastatic disease, is a so-called lumbar puncture. Our whole brain and spine is surrounded by fluid, which is called the CSF. And maybe some of you have seen it's a little bit the same thing if you are delivering a baby and you're getting an epidural, you're getting in this space. In this case, you're injecting something. For us, it's the other way around. We are analyzing this fluid. Again, the timing is really, really important. You would think, again, you're in the surgery, the surgeon is mobilizing the tumor and tumor cells, and you cannot get all the millions of cells out. So then we have some cells floating around. So if we would do this investigation 2 days after, everyone would be positive for cancer cells. Well, so we have to wait a certain time, 10 to 14 days after the surgery again to settle. That's also a good thing because every patient needs some recovery from a big surgery like this. All other investigations are not standardized. As I told you, because outside of the brain and spine to have metastasis is really rare, so we don't do anything else unstandard, just if it's needed. Some imaging, and for all of you who are not so familiar with it, so you can cut in 3 different levels. You can either cut through like this or like this. And what you can see on the left-hand side, this is your nose, what you can see here, and it's a cut like this. And I try to show, now I still need the laser pointer, sorry. What you can see here, so this would be your nose. This is so-called the brainstem, which is going down in the spinal cord. And this is your cerebellum. And what's not belonging there is this part here, which is a little bit lighter than the rest of your brain. What you can also see here, and that explained what happened to Josh as well, if you're blocking this here, normally your fluid is really going down here around the spinal cord. So mechanically, you have something pressing on this, though the fluid gets stuck up on here, and you can see that the ventricles here, so these are chambers with our fluid in, are getting bigger. With this getting bigger, you're increasing the pressure in your brain. And if you have increased pressure in your brain, you get some vomiting because it's also pressing here on the vomiting center, and you get some headaches. So Josh had kind of a classical presentation of a tumor like this. Here you can see it like even better, and this is like always the first thing for the surgeon to determine how quickly he has to intervene. The longer the pressure, the more you're damaging the normal brain. So that's just like the first intervention. In best case scenario, we always try to fix two things at the same time, meaning leading the pressure down as well as take the tumor out. I will also show you a little bit what we are understanding under metastatic disease, and you have to believe me a little bit. So if you can see here your tumor, can you see all this white stuff here? That's not normal. So here you have even some nodular component. Sometimes it can just be like some linear enhancement, which is like a little bit called sugar coating, which sounds like a nice thing, but it's like really, really a bad thing. So as you can see here, this patient has really disease all along the spine. Very important for us to know again, because we have to like really adjust the treatment appropriately. The first step is quite obviously the surgeon. So one thing is, like we call this, like if the chambers with the fluids are going up hydrocephalus, and there are different possibilities to do so. We are very fortunate in the center here to have pediatric neurosurgeons. So it's almost never a question that they would really go in, take the primary tumor out, and with this also can fix the chambers and the fluid goes down. In case it's an emergency and the child is somewhere out in the community, they maybe have to just take care of this and with this stabilize the patient to get us here. But for a pediatric center, this is pretty much the standard. And Sheila, you can correct me if I'm saying something wrong. Surgery there, and I will demonstrate this to you a little bit, is a relatively challenging surgery. Because as you can see in the brain, everything is like relatively compact. It's not that you can just open it up and make a nice room and see where things are. So there's a lot of things like how are you positioning your patient? And this is a big task. That's why you're sometimes wondering, the surgery alone is maybe like 2 or 3 hours, but you see, oh, why is the patient already there like an hour before? Because it takes a lot of like preparation that the anesthesia as well as the neurosurgeon is happy with the whole positioning. And it truly takes a good team, what we have here. And this is an experience built out over years and years and years, started with Dr. Hollenberg and goes now. It's extremely important to have anesthesiologists who are there and willing to do so and know what it means to do surgeries like this. There was the issue of positioning, bleeding, but also air embolism. So think about it, air is always going to the top. And if you're cutting like one of these big vessels and air goes in, that's one of the major things which can happen. So really complicated, difficult surgery, but that's why we're so thankful here to have the pediatric expert. And think about it, you have pressure on your brainstem, so you have to be really careful to release this pressure because of the brainstem of us like is really controlling everything, our heart rate, our breathing. So you cannot do this like just quickly and pop there, otherwise anesthesia is not happy with you either because all the vital signs go like this and then they are for sure awake. One thing which was also nicely described, which we can see as a post-operative complication, is the so-called cerebellar mutism syndrome or posterior fossa syndrome. It's hard to predict when this is going to happen. We have a lot of theory about this. It's maybe dependent where the surgeon is going through. Bottom line is, I mean, there is no choice. You have to go in there and take the tumor out. But it's really hard on the parents and also on us. The patient is not speaking. It's really irritable, can't control himself, and is extremely miserable. And for us, it's extremely hard to control this. We know it's going away, but we don't know when. For some, it's only a few weeks, but for other patients, it can go up to a year. And it's really hard. I mean, we're working with rehab on this, but only like honestly time will tell and will make it better. But that's one of the big challenges, especially at the beginning, and really, really hard on the families. Because communication, you know, is a really big part of like to figure out how a person feels and stuff like this, pain and everything else. We have some indirect signs, but this is a really big thing for us, like really giving the best care and the best supportive care if you're not able to communicate. And this is a little bit like how the surgeon sees this. And you can see that there are a lot of blood vessels, there are like cranial nerves, and you're like working in a really, really tiny space with your microscope with like really tiny instrument. and you cannot go like a millimeter out because then otherwise you hurt something. So we always have like a pre-operative discussion really, and always we ensure the neurosurgeon, and they know they will take out as much as they can, but not with causing further harm. Because we're now in the fortunate like situation that we can do something if there is any residual left. So we don't all have to do it surgically. And I think that's something where the teamwork is really, really important, and the team approach and a lot of discussion beforehand. I told you a little bit before, our pathologists are getting better. So at some point, even like with all our like really doing and describing this, they were like, oh, but this medulloblastoma doesn't look the same as the other one. So in the meantime, you can see here we have a list of like 5 different subtypes, which are all described by the eye only. So some of you will maybe do, And yes, we share this a little bit because you need an extremely good pathologist, someone who does this on a regular basis, who is like really in discussion with their colleagues to make this right. Because for us, as you have seen before, a lot of things are dependent on this. For me, it changes the treatment completely, whether it's an anaplastic subtype. And you will also see this had made a huge like really difference with regards to outcomes once we have connected the subtypes with the overall outcome. As you can see here, we learned certain subtypes have a better outcome than others. How can we react on this? So we could say the ones who have like a lower outcome, we maybe have to intensify their treatment to get to the same numbers. Or you could argue on the other hand, someone like a classic one, maybe we can lower the treatment a little bit and would still get like to the same number. And that's how we're constantly changing our treatment protocols. That's also a thing which is really special to pediatrics. Worldwide, we're sharing data. The Europeans have their protocol, and more or less we have our protocol, and we're sharing data all the time. The protocols are quite similar. Because if you're thinking like really the low number of patients, we have to really get all the clinical data from every patient. And only if we have this 100, 200, 300 and analyze this data, we can move forward. That's why we are all worldwide connected and sharing all of this data. One of the really interesting findings was that not every subtype means the same for every age. And the really striking finding was in infants, so in less than 3-year-old. Look at the big difference of a desmoplastic, which is the upper curve, which has an excellent survival, compared to the classic ones. And if you're especially thinking you have a small child where you're always a little bit itchy how intense you should treat because you're really worried they're much earlier in their development, can we really lower the treatment a little bit and resist all the toxicity for desmoplastic subtype, but have to intensify it in the classic subtype? And it all comes down to one of the big components in our treatment, which is radiation. Radiation, as good as it is for tumor control, it has quite some severe side effects with regards to neurocognition, especially in the long run. So even as we are getting better and better to really deliver the main dose only on the tumor and have hardly any dose on the surrounding brain, but it's not zero, even with all the advancement we have to make. And if you think you have a child which is 1 to 3 years old, where the brain is much more vulnerable and still developing, we don't really want to radiate this. So are there like really other ways we can do and still get them for long-term survival? Which also means you need some guy who comes up with a really crazy idea. In this case, it was a German guy, and he was like, is there anything which will be maybe as good as radiation therapy for this younger age group? Remember back when I told you how we're doing a lumbar puncture and take the CSF out? We could also use this route to inject some chemotherapy. So you have the direct effect only on the fluid around. How much do you have to do this to get through the same effect as radiation therapy? And it's all the time a poke. So is there something we could do this nicer? And you know how I'm like telling you the story? Yes, there is. You can put in a little reservoir here and put it like in one of the big chambers here and directly inject. And they tried this for their infant group. And the outcome was exactly the same as compared to radiation. That was one first important step. But the second more important step is what you're seeing here, because we wanted to prove that with this we cause less neurotoxicity than we're doing with the radiation. And what they compared, so these are like normal, healthy infants. They compared this one to kids who only got the systemic chemotherapy. So that doesn't mean that they got like chemotherapy directly get injected into their CSF. You can see there is a certain difference, but not a lot. But the important thing really to look at is that this one, which was the approach for the infant group, compared to this two who both had radiation therapy. And this are relatively early data, which for sure we have to follow up. But it seems to be that it is not as toxic on the developing brain than it is to do radiotherapy. Was a major step for us because, as I told you at the beginning, we really have to look ahead and see what's happening over the next 10, 20, 30, 40 years. So this is something which is like now well implemented, but now the second question is, if it works for 3-year-old, wouldn't it not work in 4, 5, 6-year-olds? Or when is like really the time where we can do safely radiation? And this is currently under investigation. A lot of protocols have moved up from 3-year-old target to 4-year-old. You could argue our brain is still developing, like even at our age, so maybe there is never 100% a safe one, but that really maybe we can put this like out a little bit just to minimize toxicity. Important for us is really everything we do, we have to look at long-term outcome. And this is something, and that's why it is important to be like really frank to the parents, to discuss with them what could be potential long-term side effects. And why is this important? If we know what potential effects are, we can monitor for this. If we monitor, we maybe detect them early, and then we can do something about it. One of the big issues, which is still for hard to assess, is neurocognitive. Because like not everyone has the same sensitivity through the radiation, and you also know each person is different. It makes a huge difference if you're starting with an IQ of 140 or 1 of 100 if you're thinking about this. And there is only so much you can really do. And think about all the patients are really sick, so you cannot start and do testing beforehand. You only have like indirect report. So it's extremely important to discuss this, but what can we do to like really prevent this? You have to keep the brain challenged, and that's what we're telling all of our parents. So exactly the same thing, they have to keep challenged, and something like exercise, what Josh is doing, makes a huge, huge difference, and we have tons of data of this. Biking, you know, you have to also have a certain coordination, you have to eye, hand and stuff like this. Extremely good exercise for the brain, extremely important. Neuroendocrine, that means all our hormones. Standard for us, it's testing and blood test. That's at least something we can substitute and really take care of. Bone and soft tissue. If you can't walk around for a little time and you can't like really have your regular diet, that doesn't help your bone health. So it's really important once like we're getting to the end of treatment to get them back on track, which means back to a good activity level and to a good balanced diet. There's a lot of things you can take, vitamin D, calcium, but it will still not substitute going back to a regular diet and some activity. Behavioral issues, and that's mainly think about the treatment. A lot of kids are in treatment for a year, are in and out of the hospital, are away from their peers. So it's a little bit like a whole different world, and then they should go back to like really their normal life, which is a new normal anyway. But like this part often is like there's a whole thing like you're excited about this, but you're also scared because you feel you miss part of it. And this is also like really a big job for us to make sure that this integration helps. We always encourage like all the colleagues, friends, and so to come to the hospital. So they don't like really use this whole year, and we try to provide them like as much education as you can. We have one of the nurses going into schools and does the same thing to really get them as much as we can to the normal life of before. Secondary malignancy. That's something which we may see more as we have more and more survivors, but that's a little bit of a gray area. We try with all the dose reduction we do also minimize this rate. That's again something we are really like looking out for. Every patient who starts treatment with us has more or less a lifelong relationship with us. We don't let them go. They're turning 18. Sorry, Josh, you're still with us until we see like most likely us retiring and you have your own family. It's extremely important as we learn more and more and getting more and more experts. And you heard a little bit from Josh about all the neurological sequelae, which is a whole combination. Bottom line is We try to treat a highly aggressive tumor with aggressive treatment, and there is no way you have not certain side effects, unfortunately, but we try to minimize them as much as we can. Treatment, as we already discussed, it's a combo of everything we have at the moment. Certain centers are also going more intensified and use high-dose chemotherapy, so they dose it like higher and then need their own stem cells to rescue the patient so that they can recover their blood counts again. That's even more aggressive, and it's really for this like high-risk group patients to see that we can overcome like their aggressive tumor. If you remember back, the first picture I showed you, and I have to like really end this on a positive note, tumor gone. And not just like gone for a little bit, like we're quite a few times out. And that's hopefully how clear a scan should look like in the follow-up. Same thing with the other patient where we remember all the spinal disease, clear. And we will follow this. And we like to take a lot of pictures in the long run because we always like to have this reassurance, even if the patient is really doing well, but also for us like to really see. And look at these numbers. It's not 100%. I don't think it will ever be 100%, but I think we have a lot of improvement done over the years. 80 to 90% in average risk is a little bit maybe on the max, which we can get there. To get anything over 90% is really tricky because like even in a good risk group, you will still have some treatment-resistant one. The high-risk group where we started like really even like 10, 15 years ago, and they had 25%, we're now to 60 to 70%. The big issue with this disease remains once it comes back, we don't have really find an answer to treat it then successfully again. So the first shot, as I would like to call it sometimes to explain, is the best one, and that's where it's so aggressive. So we can't like really hold up and do something more mild and not to buy as many of the side effects. We only get this one really, really good chance. And hopefully that's something the more we understand, and Dr. Singh will point out, we hopefully can overcome this a little bit with some of the newer stuff. I want to share with you at the end some data just for Canada. We made a huge effort to really collect data in all the 16 centers across the country. And we had enrolled 559 patients over like this 21-year period. So we have around 27 cases in Canada. Not a big number, I completely agree, but I think a really important number. Median age 6 years, that's what we see, a little bit of male predominance. And then you can see here, most of them are M0, which means post-surgery there is no tumor left, at least not how we can prove it. That does not mean that there is not some like disease we can't prove on any imaging. And one is then just like there is a little bit of a residual from the surgeon, but you can see here, the one I told you like outside of the brain and spine was only 1% over this like really long period. Look a little bit at this. So there is we don't know why it is distributed like this, or maybe we will have an answer soon. The big thing is like even over this long period, we have like almost 60% survivors. The lost in follow-up is a little bit, not every center is as fortunate as ours that we can just keep the patient in the same clinic. There are quite a few centers who once you're 18, you have to be transferred. And unfortunately in this transfer process, even if you try to make it as smoothly as possible, certain patients are lost in follow-up. That does not mean that they are not alive, but we just don't have any follow-up data on them. Where at the moment still we are the expert, meaning we try to teach family physicians and people in the community to take this over. But if you're seeing how many patients we have a year, this will take years and years and years to really build up the knowledge there that someone feels comfortable to take this over. So I think for the next years it will be here. And we're really fortunate here in the province. We have a really, really strong support and funding for the whole what we're calling aftercare program, which is definitively more than most provinces can offer at the moment. So where are we going from now? And just to make it easier for Dr. Singh to take over now, the idea is to have more individualized treatment in the future. So can we really target it down to the individualized tumor, to the individualized patient, to maximize the good outcome, but to minimize all the side effects and toxicity?